Okay, might start it off, and some people might join as we start. We want to make sure that we're on time, so that everyone can ask lots of questions and give the time this kind of presentation deserves, because it's an area which a lot of us in general practice and elsewhere are seeing more and more. I think that we'll go into the context, but around post the pandemic, if you can call what we're in now post pandemic, there's a lot more, I found, people coming in post travel with fever or some kind of illness, probably than before. Is that heightened awareness of it? So I'm probably seeing a lot more than I would have done beforehand. And so fever and the return traveller, what not to miss. Next slide, please. Oh, thank you. My name is Morgan. I'm a GP in northern suburbs of Melbourne, and do some work with integration, the virtual specialist consults with general practice. So if there's anything we can do to improve that interface or any feedback, very keen to hear from you all. And we're actively working at the moment with the college and also with the Department of Health to get those patient and support item numbers changed so that you'd be able to access them without needing the non-GP specialist to bill as well. So we'll keep everyone updated on that, but hopefully some movement soon. The college is involved as well. Next slide, please. And we'd like to acknowledge the traditional custodians of the land on which our health service is built. Those are the Taungurung and Wurundjeri people, and acknowledge their continuing connection to land, waters and community, and pay our respects to the people, the cultures and the elders past and present, and also to mention that there's a new collaboration between VSC with the Victorian Aboriginal community-controlled health organisations. Collaboration launched during Reconciliation Week, and we'll see VSC formalising our work with the 34 machos around Victoria to provide care on country. So that's something which everyone's really proud of, and thank you to that organisation for working alongside us. Next slide, please. So we'll keep audience mainly on listen only. We can definitely use the chat to leave any questions. We'll have question time at the end, definitely with the CPD certificate. Complete the survey at the end of the presentation to receive that. And we'll record the webinar, and we can send a copy out to you or anyone you want to show it to upon request. Next slide, please. The VSC, who we are, Virtual Specialist Consults, are a virtual health specialist service. We're available across Victoria to help try and support community health practitioners, especially GPs, accessing hospital clinics in a very timely manner from anywhere, and anyone who's finding that barrier to access to care, especially anyone who's quite rural or remote. We're really keen to get feedback on how we can improve that. And so the structure is very much around that co-consult, the GP, the patient, and the hospital. Next slide, please. The 3 access models, just for anyone who is a bit new, we've got the case conference. So you can see the hospital team alongside yourself and one other healthcare provider. So for example, the practice nurse or diabetes educator on our side, but the patient doesn't have to attend, you just need their consent. The co-consult, but it's the GP and the patient meeting with the hospital specialist. And then the e-consult, which is that written short communication designed for general questions back and forth. That can all be found on the website. And next slide, I think it's only 2 more of me. Lots of specialties, and always keen to hear if there's ones that we might not have that you'd be interested in us exploring, or an increase in the number of clinics or times available. I think 1 more slide for me. Very good. So absolute pleasure to introduce Dr. Venkatesan, who is here today to talk to us about fever in the return traveller. Is an infectious disease and general medicine physician with a keen interest in tropical medicine, viral hepatitis and drug allergies, and works for VSC regularly. And we're just talking about, he used to live in Darwin and has come down here to nice sunny Melbourne. So over to you.
Thanks very much for the introduction. And good to see everyone online. Thank you for attending. And I'd also acknowledge the traditional owners of the land in which we meet today and wherever everyone is, and pay my respects to elders past, present, and emerging, and to anyone that's joining in the meeting today. And we're going to go through fever in a return traveler, which is a huge topic. And I was really trying to think about how to keep it relevant. And I think that I'd like to make this interactive. So Margaret, in the slides, if you don't mind, when I have people to, if they put in chat and put in differentials or whatever, feel free to, just list them out. That'll be great. And I'm hoping to make this, as interactive as possible, just so that we all learn something from it. And what do we want to really try and get out of this? I think we want to think about the common causes of fever in return travelers, and just acknowledging, and I'm really going to keep this very clinical and not about management, because I think we really, I think value, all of us, the clinical interactions and the clinical assessment and the clinical acumen. And I think that even with everything that's happening in the sphere of automation, machine learning, large language models, that clinical medicine is who we are, and we need to know it. And the better we are at it, the better clinicians will be. And so I'm going to try and keep it as clinical as possible and focus a little bit on some typical and atypical presentations. And we'll go through lots of times incubation periods and timelines of certain infections, and for each of the conditions, when and who to escalate to. And this is not meant to be, a large contemporaneous overview of every single condition that's out there. What I'm really hoping to achieve is, talk about a framework of how we or I would approach these presentations. Because, at the end of the day, there's always new things. There's always new, we have to keep abreast. We're always in the limelight with new conditions that keep popping up. And this was from January this year, and already this list is going to be updated. And I'll go through at the end what some of the viruses that we worry about are at the end. And I'm hoping to finish on a positive note, not on a bummy, depressing note. And I think that, this was, speaking of heart sync moments, is when I'm sure you've all been in the consultation where you've just done a 15-minute consult, 20-minute consult, and the patient, as they're walking out, oh, I'm heading overseas next week. Is there anything I need to watch out? I'm planning to go whitewater rafting and to a Muay Thai camp in Thailand for 2 weeks in the middle of the jungle. Oh, great. And so, it's a hard thing. You're not going to have a chance to do a thorough plan. But this was a really excellent review article. In fact, by as Morgan mentioned, I lived in Darwin for 6 years, worked in Darwin for 6 years. I had the pleasure of working there. And I actually know this GP. And it's a really, really nice article that goes through various key bits of a travel assessment. Because if we prevent, is much better, obviously. And the pre-travel planning by assessing someone's past medical and really their immunization history, and if they're immunosuppressed or not, is really going to make a big difference. And working out what have they done previously, what are they planning to do this time, where are they planning to go, they planning to do any at-risk activities, and when are they going, how long are they going for, and are they doing anything that's going to be of concern? Having that structure and framework would be great for a pre-travel plan. And I know a lot of you probably do travel clinics and travel medicine as part of your routine day-to-day work. But for those that don't, or those that are more interested, this was actually a very nice article if you're interested in reading it at your leisure. So we'll get straight to the cases. So we've first got a 48-year-old male, and it's a telehealth assessment, this one, and they call in because he's just been absolutely lousy. He's been fatigued and just run down for the last 3 days. He's had a fever for close to 2 days at proper temperatures of 39 degrees. And today, or the last 1 or 2 days, he's also had diarrhea and some mild abdominal pain. And he has come back from Phuket 4 days ago, where he was there for 2 weeks with his wife. And he says he stayed in a resort for the whole time, except for a couple of times where he went down to the beach and spent a bit of time at the beach. He has no past medical history, and he's Australian born, and he was born in 1978. And so the key bits here are fever for 2 days, some gastrointestinal symptoms, and just feeling absolutely lousy. And when you see him through the limits of the telehealth, I can't put abdomen soft and non-tender. You're not assessing him, but he pokes it himself and he says it's not tender. But you notice he's got a bit of life. Is someone? I can hear someone's audio. If you don't mind muting that, that would be great. I'm not sure who that is. On exam, you notice that he feels absolutely flat, but he's sunburnt. And you think, oh, is it a sunburn or is it a rash on the trunk? You're not quite sure. But certainly he's got some injection and irritation looking at light. So straight into it, do people, if you're interested or if you're keen, enter into the chat what you would be worried about, or what are the differentials that are coming that would make you concerned, if you like, and if you what really worries you.
Ready to shout some out. I'll say malaria. Malaria. That's what I was
always
taught.
Good to do that. Yeah. Always good to think about that.
Meningitis.
Yeah, meningitis is a great one. Yep. In the interest of time, we'll keep moving along because those are some really great differentials. And so how I often approach this is, I like to think of, well, what's going to cause this patient to get sick depending on the incubation period of the illness. And this was a really lovely article from 2002. But unfortunately, this needs to be updated because since then there's a lot of other conditions. And so as with everything, this list has gotten bigger, unfortunately. And so this is your bigger list of things to think about. And so, it's a short incubation period. So we worry about things on the left-hand side of the screen. We certainly should think of malaria, but I think there's very low risk of malaria in Phuket. We should think of meningococcus and meningitis, as someone correctly said. There are a few other things there that are listed, which we would be thinking of, such as arbovirus or other flaviviruses as well. And in this list, one of there's a condition that's missing, which I'm particularly worried about in a gentleman that's born in the 1970s, and he's got these symptoms. Certainly it still could be dengue. It could be measles. It could be COVID-19. Yeah. And as we spoke about, it could be some of the coccal infections, your streptococcal, your staphylococcal, and a few others listed there as meningococcal. But in the interest of, things not to miss, I'm sure a lot of others have also been thinking of, what about measles? And why would we suspect measles in this patient? Well, we'll go through the list and explain why. But before that, we are seeing a lot of measles. And we are seeing, if you just go to the Department of Health list of, exposure sites to measles, you see patients that present to either clinics multiple times or to emergency department multiple times or to urgent care center multiple times. And we are, really, as Australia lost, Australia has effectively since 2014, we are seeing a huge number of cases, and it's also we're seeing a drop in the second measles vaccine rates since the COVID-19 pandemic. And we're seeing outbreak of measles across the US for various geopolitical and social reasons, and across multiple other parts of the world, Southeast Asia, in Africa, and in Europe as well. And the vaccination is the best and the safest way to protect yourself, and I think we all know that. What I want to focus on, as I said, is the clinical features, and it's a condition which can really catch you off guard. And I brought this case up because it actually caught me off guard on my last day of infectious diseases on call at the hospital, where the patient predominantly had gastrointestinal symptoms and no eye symptoms, according to what was told to me over the phone, and no rash. But he did come from overseas. And what had happened was the rash, people assumed it was sunburn, but it was actually the maculopapular rash patient that was slightly dark skinned. And so had a different skin tone. And so it wasn't picked up. And therefore, that meant a huge contact tracing had to be undertaken because the diagnosis was missed for up to 12 hours. And so it catches all of us off guard. And that's the reason we're bringing it up, is acknowledging that it's very, very challenging, but it's really important to think about it all the time. And we know that the viremic phase is when they are most contagious. And we say day 0, the day -4 is when they're contagious. And the day 0 is the start of the rash. And you're contagious for 4 days before the rash starts. So this guy has been infectious for, potentially a few days before he came in. Before the rash, though, you often get the prodrome of malaise, fever, and the classic 3 Cs, which is your cough, coryza, and conjunctivitis. The Koplik spots are interesting because it's very hard to see, and we do see it occasionally, but it often is 24 hours around the time of the fever, before or after. And you're considered contagious or infectious for 4 days after the rash. And during that period, patients just feel absolutely lousy. But what happens after that is you get the complications. You get your pneumonitis, hepatitis, gastroenteritis, otitis media, and then a little while later, you can get secondary bacterial pneumonias. The ocular symptoms and ocular complications are particularly nasty in children, especially when there's corneal ulceration or perforation that happens in patients that are vitamin A deficient. So not so much a problem in high-income countries, but certainly if you're malnourished or in low-income countries, it's a big deal. Following this, it causes a really nasty amnestic immune response where the CD4 count just diminishes drastically, paving the way for infectious and other complications. And so you're at risk of secondary bacterial infections for a period after that. And that risk goes on for up to a year to 2 years sometimes. COVID-19 also causes a reduction in lymphocytes like this as well. The measles-associated encephalitis, you can get 3 different forms. There's the form that you get very early on in the first week, and that's the post-viral encephalitis, not your typical acute disseminated encephalomyelitis, but your post-viral encephalitis. And then following that for a few weeks, you can get an inclusion body type presentation. Following that, 6 months to many, many years after that is the unfortunately horrendous complication of subacute sclerosing panencephalitis, or SSPE, which is classically associated with myoclonus, and essentially it's nothing. It's a horrible complication. And so that's the reason we don't want it. Is all of these reasons. We want to vaccinate. We want to be protected. And just more, the rash really, it catches us off guard, because if you're not vaccinated, it presents typically, and it starts with the rash around the forehead or ears, and then it spreads out. And it's really important because that's a classic history in an unvaccinated or partially vaccinated patient. The rash starts from the face and then goes everywhere. And that's what we, really make our judgment on. Is we hear that, we go, why is this not measles? And then over a few days, it becomes maculopapular, more raised. And then you get the really typical intensely red scarlet fever, like morbilliform rash. And patients often describe they feel like sandpaper. But there's one thing that's for certain: patients will feel absolutely miserable when they're experiencing this. And as we said, the Koplik spots, you can see the from the arrow there, it's usually around the time of onset, or within the time of the fever as well. very hard to see and not seen very commonly, but if you see it, it's pathognomonic of measles. And I remember we actually, the start of an outbreak was when we picked up one of these rashes in a clinical scenario a few years ago. And this is the variation I was alluding to, where you can get that really fine sandpaper-like rash. But in children or persons that are more with dark skin and or have darker skin tones, rash behaves differently and it looks differently. And we need to really change our heuristic thinking of this doesn't look like a typical measles rash to could this be measles, and really think about that question because it looks different. And many of you on the presentation today would have had this experience, or if you've worked overseas, or if you've seen this in outbreak settings. And you can see that, for example, the only normal spots on the picture on the top right, the white spots are the normal skin, and everything else is the morbilliform rash. And you can just see just does not look typical of what we would see in someone with a different skin tone. To complicate it further, if you've only had one and sometimes even two vaccines and your immunity goes down, what we call secondary vaccine failure, you can get this syndrome called modified measles. And again, we can get caught out because it doesn't typically start on the face. It can start sometimes in the trunk, and it goes it doesn't start on the face. But that's often associated with mild symptoms. Fever is often lower, the viral load is often lower, and there's a lower risk of transmission. And so modified measles syndrome still catches us out occasionally. And so even if you're 1 or 2 doses, it's important to think about it. We don't get atypical measles anymore because we don't use the inactivated killed vaccine. But the reason we need to think about other atypical presentation is if you're immunosuppressed. But if you're malnourished or pregnant or immunosuppressed, unfortunately, you also have more complications. And so you might see patients that got over the early phase and they present with a complication. So in this case, maybe if people wanted to, have a think about, would you organize, he's a telehealth patient, would you organize for urgent testing for, dengue, malaria, and measles because you don't want to miss that? Or would you just say, oh, look, why don't we just monitor and see how it goes? Or would you ask the patient to present to the ED because you're worried about, this could be measles and a few other conditions? Or do you home isolate and call the public health unit? If anyone wants to enter it in the chat, feel free. But if not, in the interest of time, we might keep moving on. I think the right thing to do here is to call the Department of Health because measles is an urgent notifiable condition that must be notified by medical practitioners immediately upon suspicion to the Department of Health. And what they will do is they will go through the clinical features, the risk, the epidemiological risk, and tell you whether this is a low, medium, or high risk, and does it warrant testing or not, and what should be done. And so that's the key message that I'm trying to get across is suspect measles. And if you suspect measles, you have to pick up the phone and call Department of Health and call your local public health unit, depending on whichever part of Victoria you are, or if you're interstate, wherever in your local public health unit. If you're concerned the patient is really unwell and they need to go into the emergency department, please pre-notify wherever they're going to go, because it has massive implications because of the reproductive number and the infectiousness. And as you know, it's the highest reproductive number in terms of infectiousness. And we need to be notified so that the patient can be appropriately collected, immediately goes into a negative pressure room, and minimize risk of exposure to other patients. But for the sake of knowing what we would do for testing, the best test is the nose and throat swab, the nasopharyngeal swab. We don't do cultures at all, usually, and we sometimes do urine PCR. We use serology sometimes to test for, if you're protected or not. But the caveat with serology is that, it's only 50% at day 4 and, increases after 1 week, but most patients present much earlier, and we really don't use that. And so the overall management, some key points are, if you're not admitting them and the Department of Health say they need to be home isolated, you keep them isolated at home and they stay at home. They don't go to school. They don't go shopping. They don't go to childcare. They stay at home. And they stay at home for 4 days after the onset of the rash, which is when the infectiousness, they're not infectious anymore. If they're admitted, as I said, pre-notify, and they'll go immediately into airborne precautions, and we monitor and treat for complications. The role for vitamin A, especially in children, is hotly debated, and the guidelines still recommend that we do give it. But there's a lot of nuance to this coming up, and some discussions around, is this better to be given only in those? If you're in a high-income country, do you select people rather than giving it to everyone because of the risk of toxicity of vitamin A? Although there's no evidence of toxicity of vitamin A from measles treatment, there's a theoretical risk, but there's a working space. We're work in progress for this. The contact tracing and post-exposure prophylaxis is massive, and what we really try and do is try and vaccinate close contacts within 72 hours. And Department of Health will guide you on who and what is considered a close contact. And if you can't be vaccinated within 72 hours because it's a live vaccine, say you're pregnant or immunosuppressed, as per the immunization guidebook conditions, we need the human immunoglobulin. And we use human, the immunoglobulin ideally up, as soon as, after the 72 hours, but you can give it up to 144 hours or 6 days. And there was a really excellent fact sheet and checklist on the RACGP website, which if you have a clinic, or if you own a clinic, or if you run a clinic, or if you work in a clinic where you might see patients with measles, I would, you probably have seen this already, but having this measles preparation, response, and recovery checklist, I think is it was a really, really, really nice practical approach of, how do you prepare for a potential, measles exposure, and what should you do if they are exposed, and what's the recovery that needs to be done after that. So as a practice manager, or as a practice owner, or even or otherwise, even as a someone that works in a practice, something to look at. Right. Let's move on to case 2. Just as I said, this is not meant to be things you've never seen, but really talking about the common things so that we really appreciate the clinical features of it. So in case 2, you've got a 23-year-old female that actually turns up to your practice this time, and she's again fatigued and run down for 3 days. She's had a fever for 2 days, and she's had a headache for a day, and she's got some flank and thigh pain as well. And she's also sunburned because she's come back from Bali 3 days ago, and she spent 2 weeks there with her friends. And she drank a lot and had a good time and had lots of sun exposure. And she has no relevant past history. She was born in 2003, and she's up to date with her immunizations. And you have a quick look and you see she's actually had 2 doses of her measles vaccine as well. And on exam, you see that she's febrile. She looks miserable, and she's a little tachycardic. She's got a respirate of 16, and her blood pressure is probably okay for a 20-year-old, but maybe a little low, 94 on 60, and that maybe you're worried about the diastolic. There's sunburnt appearance of her skin, but you can see that there's patches of maculopapular rash, and it's not so faint anymore on this picture, but imagine that it's a bit more faint than this. And her eyes, there's periorbital swelling and pain, tenderness, and the abdomen. Again, there's mild generalized tenderness, maybe more on the right and left upper quadrant, but just generally she's tender and miserable. So again, not meant to be very, very, it's not a, not trying to make it complicated, but what are the things we shouldn't miss and what are the things that we'll be worried about? Again, feel free to either enter it in the chat or if you want to yell out, feel free to yell out.
Malaria.
Yeah, excellent suggestions again. Let's go back through this again, and it could fit many of these things. It could fit chikungunya, but you didn't see the real typical arthritis or joint symptoms, which is very prominent. Could be influenza. It could be lepto, especially if there's ocular eye-type symptoms and they've got a fever. Malaria, yes, but lower risk of malaria in Bali, again, although we still worry about it. Could it be any of the coccal infections? Sure. But we, and as you know, meningococcal can present with a macular rash rather than a non-blanching rash in the, early on. So it's always important to think about that. Could it be Zika? Yeah, sure. Because this is a short incubation, again, we're looking at the diagnosis on the left. It's not going to be any of the other conditions because they take a lot longer. So I've come up with a list here of things that I'm worried about. It could be dengue, it could be measles, but I think it's less likely because she didn't have the typical features and she's got 2 documented immunization history, as we see. Influenza, but typically doesn't have a rash. COVID-19, again, always worry about, and you get a test with all 2, 3 of them anyway. Could be chikungunya, but as I said, less likely because I didn't see the typical really prominent joint arthralgias that you can get. But it's very hard to sometimes clinically distinguish dengue and chikungunya. It could be other flaviviral infections like Zika. And I would still be thinking of, could this be a coccal infection? Or could this be leptospirosis or enteric fever? Enteric fever is less likely because the incubation period is too short. And rickettsial, you have a good look. You can't see an eschar. But always good to think about that as well in patients that have just come from, that are sick, that have come or have appropriate risk. And so clinically, when I see patients with dengue or chikungunya or Zika, I think to me, if I see really prominent conjunctivitis, it fits more with Zika rather than the other 2. If I see really prominent arthritis and arthralgias, it fits more with chikungunya than dengue and Zika. And if I see really classic headaches, retroorbital pain, it could be chikungunya or dengue, but I think more dengue. The rash really actually doesn't help distinguish any of those 3. But if you see patients with red flag symptoms like hemorrhage, bleeding, or shock, it's going to be dengue, and that's what we worry about. So let's say we suspect this is dengue. Let's dive into dengue. It's a flavivirus, as many of you would know, and there's 4 serotypes, 1, 2, 3, and 4. And the vector is the Aedes species. Now, while Australia, there's no endemic dengue in Australia, we do have the vector, the Aedes mosquito, particularly in northern parts of Australia. And so there is a theoretical risk it could be coming. And there is endemic dengue, for example, further north in Torres Strait, and chikungunya. And so we have modeled by 2018 that this whole equatorial and subequatorial region may be suitable for dengue, and that region has increased dramatically, will increase dramatically in the next 50 years because of global warming. And we're talking about billions of people at risk of a nasty infection. And it's nasty because there's 4 serotypes, and so all 4 of them can cause severe disease. And it's, you would all know that it's not the first time, but the second infection that often tends to cause severe infection. And that's because of this phenomenon called the antibody dependent enhancement. And so when you first get the infection, there's a protective interferon type response, and there's effective cytotoxic, attenuation of the virus. But with this further infections, what happens is with this antibody-dependent enhancement of myeloid cells, it really goes and lets the virus loose, and so you get more severe disease. Is the oversimplified answer. And 2 and 4 tend to cause more secondary, and 1 and 3 tend to cause more primary, but again, more epi data rather than anything else. But the important thing is all 4 of them can cause severe disease. And the clinical features, again, we're going to spend a bit of time on this because, as I said, we're really focusing on clinical features today. Patients will come to you, and you need to know that there's 3 key phases of dengue that we all worry about. And again, acknowledging that a lot of you might have actually seen a lot of dengue working, or if you've ever, worked overseas. But we know when we have returned travelers, they usually present in the febrile phase, rarely in the critical phase as well. So we need to know about those 2 phases. So there's a febrile, critical, and recovery phase. The febrile phase is that where the patients have a fever, malaise, rash, typical severe retroorbital headache, bone-breaking fever, very severe myalgias. And the fever syndrome that we classically describe dengue is a saddleback fever, where it's really bad for a few days and then it gets better, and then you can get another real little bump a few days after that. Why is it important to follow the temperature? Because when patients start to get afebrile, patients feel better, they think they're getting better, but that's when I get worried. That's when we all get worried, I'm sure, is because that's when the critical phase starts. And that's when there's risk of extravasation of fluid and thrombocytopenia and ascites and fluid effusions and complications. And the hematocrit starts to go up as well. And so we need to know exactly what their temperatures have been. And if they're starting to become afebrile, I'll tell you what I told my mom when she called me and said, oh yeah, I've got dengue. I've had a high fever today. And the next day I got dengue, but today I'm feeling much better. The fever has gone down. And I went, actually, that's when you need to be monitoring yourself even more closely. So we need to monitor people really, really closely at this time. And, it's very hard to do that. And some of you may do that and have systems to do that. But there are, for example, some hospitals run a dengue at home. If you're well enough to do that, others get admitted and we monitor them in hospital because they're at risk of that critical phase. And that corresponds again to the non-structural protein or NS1 antigen, where it's initially up and then it comes down as the temperature comes down and the immune response starts to come up. So after that, in the critical phase, we again look for thrombocytopenia on bloods and the hematocrit going up. But clinically, we're looking for patients that have risk of, and the warning signs. And I'll go through the warning signs in a little bit. Actually, the good thing is a lot of patients don't have the critical phase and they end up okay, and they're often moved straight to the recovery phase. So there's 3 things that could happen, and the WHO has reclassified dengue rather than dengue, hemorrhagic fever, dengue severe septic shock syndrome. It's gone to dengue without warning signs, dengue with warning signs, or severe dengue. And so, if you've got a diagnosis of dengue and you've confirmed it with an NS1 antigen or other testing, you look for warning signs. And the warning signs are abdominal pain, vomiting, if they're starting to bleed, either from the gums or GI tract, if there's a liver enlargement or hepatomegaly, if there's ascites or pleural effusions, or if you see that there's increase in hematocrit. The thing that's not listed there also is there's features of shock. And the features of shock that I worry about are particularly, thready pulse, tachycardia, narrow pulse pressure and a raised diastolic blood pressure, that often is a big red flag for me as well clinically when I worry about dengue. But let's say your patient doesn't have any warning signs, you can safely monitor them as outpatients. But obviously, feel free to call your local infectious disease team or have a system of following them up. But if you have patients with warning signs or risk factors, or they're severely unwell, or there's risk of plasma leakage or organ dysfunction, by that time they'll probably be in hospital anyway. So in the interest of time, I'm going to keep moving along. But in this patient, I don't think you're going to monitor or organize for. You could organize for urgent testing, but you're not going to do measles because it's less likely. You're probably going to ask the patient to, you're probably going to call the local infectious disease team or the local ED and go, I'm a bit worried about this patient because they're probably okay, but they're just about to go into the critical phase and they've got some abdominal tenderness and their blood pressure and their heart rate's a bit worrisome. So you probably will send them in. And so the management of dengue is largely supportive. And from a general practitioner perspective, it's really important to distinguish who's safe for outpatient versus who needs to be sent in. Patient education is really, really important if you're going to manage them as an outpatient. Avoid NSAIDs, and a lot of people would take NSAIDs early on because of the myalgias and the fevers, but really important to not do that because that increases your risk of bleeding. We really want to notify public health, just like with measles. It is a notifiable condition. But if you're admitted, what we look for is judicious calibrated intravenous fluid in patients that require it. Otherwise, we don't give fluids at all. And there's no role for steroids, and we monitor for complications. We had a lady with severe dengue a few weeks ago who was in intensive care who needed. And we followed the WHO protocol for how much fluids to give and what urine output to follow. And this was a nice, Singapore has a lot of dengue, and majority of the dengue is actually managed as outpatients. But, things to watch out for. Vaccines is an evolving space, and I think that the TG has recently approved Qdenga, but it's still not easy to get. But there's three main vaccines. There's Dengvaxia, Qdenga, and another one, TV003. They're all live vaccines, and they're all tetravalent. I think the gist of the vaccines is that it offers protection, but it seems to offer protection mostly in patients that have had infections before. And if you haven't had infections before, the Dengvaxia, for example, is associated with higher risk of hospitalization and severe dengue in the future in people that are persons that are 2 to 16. And so you really need proof of prior infection before giving it. And it's really, I think a lot of countries are having problems with this rollout. And Qdenga seems to be a little easier without those needing proof of vaccination. But if you don't have 3 or 4, there's no protection. If you're seronegative, there's no protection against dengue 3 and 4. So you need to watch out for that. So I think it's watch the space with vaccines. Last couple of cases in there, this is not, this is a 44-year-old patient that attends your practice. He's, if you notice, the symptoms are very, very similar, and I've made it that way because this is what you probably see day in, day out. He feels run down. He has a fever for 3 days, but concerningly, he's got a headache and he's vomiting today as well. And he's returned from Sudan 2 weeks ago, and he was there for 3 weeks visiting family. He doesn't drink any alcohol. He didn't travel anywhere else, and he was largely in urban regions. You had actually seen him and given him malaria prophylaxis before departure. And he has no other past history, and he's been in Australia for 20 years, and he's up to date actually with all other vaccines, and you've caught up with his immunization schedule. You actually see he's actually quite well, even though he's got those symptoms. His blood pressure is okay. He's not tachycardic. He actually looks well. There's no rash. There's no arthralgias. There's mild left upper quadrant tenderness. And as you're examining, he admits that, unfortunately, he stopped mefloquine prophylaxis 1 week into his trip. Why is that important? Well, you gave him mefloquine because you wanted to protect him from malaria. and you know that you appropriately started it before, and he needs to have continued to have taken it for a month after, but he stopped it well and truly because of various reasons. And so, what are our differentials? I don't think anyone's going to miss it here, but we're all worried about malaria here. It could still be a coccal infection or a secondary bacterial infection, and I'll explain why. Could it be TB, HIV, or syphilis? Yeah, always good to think about those as differentials as well, particularly if you've got multi-system or undifferentiated symptoms. And the key point that is that we worry about malaria, and I think everyone in this room in this meeting would be thinking of malaria as well. But it's not just malaria that I'm that I'm trying to highlight. Is that this is a patient that he looks well, but I think that he probably has a high parasite count, and he probably will be more unwell than we suspect what he looks like clinically. And that's because he's probably partially covered with the mefloquine. And so that's the point I'm trying to make, is that even though the patient looks well, he could have severe malaria. And this was the basics of malaria is we know that there's 6 species that infect humans, including falciparum, vivax, which are probably the 2 most common, but there's ovale, malariae, and Knowlesii as well, which are very common. They are also present. And the vector is the female Anopheles mosquito. And this is an excellent review article in Lancet 2023 by Professor Nicholas Anstey and Nick Douglas and team from Menzies, who I've actually had the pleasure of working with. And it's a fantastic review article if anyone wants to have a up-to-date. And there was another really great article in 2025 as well in New England, if you're interested about malaria. The problem is that we're seeing a lot of resistance to artemisinin and combination therapy, which was revolutionized and significantly improved mortality. Now, there's about 250 million cases of malaria a year, and 95% of them are in Africa. It's been a game changer, using ACT or artemisinin combination therapy. But unfortunately, as you can see in the map there, the light peach color shows that there's endemic falciparum, but there's no Kelch13 mutation, which is associated with ACT failure. The dark orange is there's some mutations that have been detected through monitoring, surveillance programs, but really the hotspot for the mutations are and ACT failure are the greater Mekong region and the Mekong, the Delta. And if you're going there, if you come back from there, there's a very real chance that we can't just use artemisinin-based therapy, and we have to give quinine as well. And so the point I was trying to make for this patient was that they don't quite have the typical features that we worry about for severe malaria when you see them in front of you, because you're not going to have the bloods and they're not hypotensive and they're not in respiratory distress. But I'm really worried about this patient because I think they might have a very high parasite count, and they might have anemia. And so you really should be sending this person in with the headaches and the nausea and the vomiting. And in fact, we know a couple of key things about falciparum malaria is in countries where there's a lot of endemicity. People often have asymptomatic or malaria in the background, and as I said, they often present with other conditions, and so there's a very high, about 5 to 12% risk of salmonella infection concurrently with malaria. And a couple of other small little clinical nuggets that about malaria. Knowlesii, which is in East Malaysia. It can cause severe disease at a lower parasite count compared to falciparum malaria, and it looks like falciparum malaria on microscopy. Vivax, uncomplicated, you manage it very similar to uncomplicated falciparum. Vivax and ovale, you can get relapses without the hypnozoital therapy, which is your permethrin or tefenaquine. And malaria can cause anemia and a nephrotic syndrome, and it can obviously present very, very late as well. The diagnostics are a reason I've highlighted this. Everyone here would do thick and thin films, which is still the gold standard. A lot of us also rely on PCRs, but the reason I say that is those panels that detect it, it doesn't tell you the parasite load. So it tells you it's there, but it doesn't tell you how much is there. And so really the thick and thin films are very, very important. And so if you're ordering a PCR, make sure you're also thinking of the thick and thin films, because that will really be the defining feature for us. The rapid diagnostic tests, the ICT tests, they detect the HRP2 antigen, particularly for falciparum. But unfortunately, the parasites become smart, and now there's mutations that allow it to, therefore, the testing has a false negative, particularly in South Africa. And so we're starting to get worried that the ICT may not be enough for diagnosing malaria as well. So I think we spoke about this. I think we're going to send this patient in. So from a malaria perspective, a couple of other small things I'd like to say is there's actually evidence that paracetamol improves outcomes, particularly from an acute kidney injury perspective. And I think that most people here will be discussing malaria with the local infectious disease team and notifying public health once you confirm the diagnosis. Last case, we're almost done. Hope everyone's still okay and still hanging in there. This is an 11-year-old boy that presents to your practice with his father. Similar symptoms, fatigue, but look at the duration. He's got it for 8 days. He's had fevers for 10 days. He's had a headache for a few days. He's been constipated for a few days, which is not normal for him, and he's anorexic. And he returned from India 3 weeks ago, where he spent a whole month with visiting family and relatives. No significant past history. He was born here, and he's up to date with his immunizations. He doesn't look great, but he's not tachycardic, and his blood pressure is probably okay for an 11-year-old, but he looks flat and tired. He's got some umbilical tenderness. There's no rash, there's no arthralgias, and there's no other lesions, and he's maybe a little yellow, maybe a little jaundiced. So this raises a wide range of differentials. Again, in the interest of time, I'll move on. But we're now talking between the intermediate to the longer duration, aren't we? So we're now thinking of things like hepatitis. We're thinking of malaria. We're thinking of, enteric fever. We're thinking of, potentially Q fever. Don't really think of melioid as often as we should, but obviously having worked in the Northern Territory, I think about it. But particularly if patients have traveled to high-risk areas, certainly good to think about it as well. Those are the infections. Again, the viral hepatitis we think about. The coccal infections we again think about. So it's always the coccal plus enteric fever. So salmonella and lepto that we always worry about. The reason lepto, it's less likely, but as you know, lepto can have a biphasic illness. It can have the initial phase and an inflammatory phase. So it is possible, but less likely. We always worry about TB, and because he's a little jaundiced, you think, oh, could this be an amoebic liver abscess? As I said, we always worry about malaria, but fever that's gone on for this long, it's important to think of other non-infective differentials like Kawasaki as well. So let's just say you go, well, I think this is salmonella because you think, you've managed enough of these conditions. And so we think it's salmonella. And so we know this salmonella is a family of the Enterobacteriaceae with a huge number, more than 2,000 serovars. And the big breakdown of salmonella is you can get typhoidal and non-typhoidal. And it's a zoonotic disease, and it's contaminated ingestion of food, from vectors, animal vectors essentially. And it can cause, the typhoidal and non-typhoidal is important because typhoidal, it either causes salmonella typhi or paratyphi, which is your enteric fevers. The non-typhoidal salmonellas are the many serovars, and all of them, they can cause either a gastroenteritis type syndrome or a bacteremia syndrome or endovascular infections or other complicated infections, including things like aneurysms, endocarditis, osteomyelitis. They can definitely do that as well. And we really worry about non-typhoidal bacteremias in patients that are vasculopaths or, of a certain age, because there's a very high chance of mycotic aneurysms in these patients. But in this patient, again, coming back to the clinical, he had low-grade fevers initially and then high temperatures. That makes you think there's a classic stepwise fever, which we don't always see, but the fact that it's gone on for so long, and patients can have a fever for up to a month before they present sometimes with enteric fever. The myalgias and malaise, the relative constipation, and you don't really get gastro symptoms with, you can, but with enteric fever or the bacteremias, it's more relative constipation. The relative bradycardia is important because the heart rate of 65 in a febrile patient should raise alarm bells, because you expect a heart rate to go up with a tachycardia, but that's not there here. And it's thought to be postulated due to many, many reasons. So we know that other intracellular infections and pathogens do it, like Q fever, Legionella, chlamydia. But that relative bradycardia, when I see it, I go, oh, could this be salmonella? We almost never see the classic rose spots, but others in the group might have previously. And the abdominal pain is either from the hepatomegaly or think about a perforated Peyer's patch as well. So again, in this patient, you're going to call that in because you're worried about how unwell he is. Salmonella usually, especially if it's enteric fever or, bacteremia, obviously always needs treatment. There's certain times, obviously, you don't need to admit patients if it's just a gastroenteritis. But the reason I want to bring this up is there's a risk of multi-drug resistant salmonella, and it's becoming a real problem because it's ceftriaxone resistant, quinolone resistant, and azithromycin resistant. And so we're really stuck, and sometimes bacterium resistant, and of course amoxicillin resistant. Ironically, we're starting to see some cases where there's actually amoxicillin susceptible because there's so little amoxicillin usage in other countries nowadays because there's so much drug resistance that we can still sometimes use it. But what I'm trying to say is we're seeing drug resistant salmonella as well. And again, you would notify public health. So in the last few minutes, what I'll take is that, we're going to summarize by saying there's a whole list of infections, but the way I really want to think about it, and I would like you to think about it, is you go, is it a short incubation, intermediate, or long? And what are the infections that I really can't miss? And I've added Mpox there because, that's obviously something that's happened over the last few years. Measles is not even on this list, but, I probably should let them know. But, coming back to the original point at the start of the presentation, we're always worried about outbreaks. And the outbreaks that, that you might have heard about in the news of late are, for example, the H5N1 outbreak around the US, where there's now transmission from wild birds to cattle and from cattle to humans, which is a big seismic shift. And so there's a risk now of human to human when it's all been typically poultry and avian. That's a big risk. You may have heard about the Oropouche virus, which is an arbovirus that, like chikungunya in the Caribbean. It's usually been around the Amazon region, but the last few years it's shifted up and it's gone to Central and South America, and it's spread by midges and it's spread by mosquitoes, and those vectors are present in North and South America, so there's that potential for transmission. You would have heard about the Hunter virus, which is, was in the news recently. But there's also measles, still a big problem. But the real big thing is, we still get outbreaks like Ebola. We had that outbreak in 2015, 2016, which was horrendous. And really, the social determinants of health is where we're failing because it's come back again. This time, it's the Bundibugyo strain, which there's no vaccine for. And so in the Democratic Republic of Congo and Uganda, there's an Ebola outbreak that's evolving. And so we always can't be thinking of every single condition, but we need to keep up to date and have a list of framework of what are the things that we can't miss. And that's where you come in, is because where I really like to say is not end on a sad note, is to say that we're all working together on this and we all rely on each other. And so having that high index of suspicion and working together of, could this be conditions that I can't miss? And being aware of the variation of presentation in a patient cohort, for example, either because of their skin tone or because of their immunosuppression, being aware of the incubation period to assist with narrowing your differentials. And once you suspect something, calling your public health or your local infectious disease team to discuss, could this be this? What do I need to do? It's all in you have the power. But you also have the power because these patients come to you, and pre-travel screening and vaccination is going to stop a lot of these conditions as well. So on that positive note, I'll end. I see that it's 8 o'clock on the dot, so I'll stop sharing. And thank you very much for listening. And these are my references if anyone's interested.
Thank you very much. And we've posted the register attendance link there in the QR, but also just in the chat if you would like to fill that in for your CPD and any feedback. Since it just hit 8, we'll close it off so everyone can get off to whatever they need to get to. But if any specific questions, would it be right if they send some emails through to us at our email, we might forward them on to you, and then we'll go from there.
And just very happy to. I think we do the e-consults as well. Where I've had some really excellent interactions with GPs for the e-consult, so that's been really great.
Yeah, absolutely. So any questions, e-consult is good. There's also the co-consult case conferences for any questions you have. Thank you all for your time, and we'll see you next time.